payer-provider convergence, using data to strengthen partnerships and drive outcomes. My name is Stacia Whelan, and I will be your moderator for today's discussion. Before we get started on today's presentation, I do have just a couple of housekeeping items. During the presentation, all participants will be in listen-only mode. Additionally, today's webinar is being recorded, and we will make that recording available to each of you by the end of this week on our website. And although the phone lines are muted, we do encourage you to ask questions during today's presentation. So please submit your questions using the chat window, which should be located on the right-hand side of your screen. And following the content today, we will open it up for Q&A. We'll go through any questions that you have, and our presenters will address all questions that come through the chat. With that, I hope you enjoyed today's webinar, and I'm happy to introduce our thought leaders and speakers for today. Our first speaker is Leslie Adams. Leslie comes to us from the Oracle Corporation. Leslie is the Director of Population Health Strategy for Oracle and has a strong background in driving healthcare technology strategies for Oracle, Tenet Healthcare Corporation, and the University of Texas MD Anderson Cancer Center. Her expertise is in population health analytics, predictive risk modeling, partner channel relationships, and enterprise data models. Leslie's experience includes academic, for-profit, integrated delivery networks, government, payers, and military healthcare systems. She is prolific in creating healthcare technology solutions opportunities. Our next speaker is David Hong, Chief Evangelist at CEO Health Analytics. In his role as the Chief Evangelist for CEO, Dave enables strategic relationships with key partner companies by understanding their needs based on the changing healthcare landscape. This in turn provides immediate feedback to CEO's product development and delivery teams on new ideas and innovation. Dave is an internationally recognized expert in the field of consumer engagement through programs such as value-based benefits and employee wellness. He joined CEO in 2009 after more than 25 years with Pitney Bowes Corporation, where he was responsible for introducing their leading-edge programs in value-based wellness and responsible for reducing medical trends. Dave has been a visionary at CEO and has helped build CEO's leading products on behavioral economic applications and a technology-enabled solution to engage members. During today's webinar, Leslie and Dave will spend time discussing key industry trends around providers and payers coming together, particularly to share data and reach value-based outcomes. They will focus on how payers and providers can overcome these challenges with a strategic approach to data and analytics. Dave and Leslie will provide insight into not only the right data that is meaningful, but how to pull meaningful insights from your data. And finally, Dave will go into a few key example insights that can be gleaned and the value of the partnership between Oracle and CEO. And with that, Leslie, I will turn it over to you.
Thank you so much. And really, this is a conversation that Dave and I have been having for several months as we've put the CEO and the Oracle partnership together from a technical integration. And just last week, we were all together in Austin for the AHIP conference. And a few months ago, we were at HIMSS in Orlando, and the conversation about this payer-provider convergence. And must admit that the convergence word's a little awkward. I think that this is more of a natural evolution and somewhat of a vertical integration of each of the sides of the industry. You know, we've got two sides. We've got payers and we've got providers. And they're both expanding their risk pools, and they're working to be collaborative and look at the 360 for the patient. So we've got providers that are starting to absorb claim information. There are some providers and health systems that are starting their own health plans, and they're identifying how that they can meet actuarial standards. And then equally on the other side, we've got payers that are buying health systems. And so it's not unnatural that the industry would stop at some point in being two fragmented parts and start thinking of themselves as one integrated part. So again, organizations and the media may want to say convergence. I just think of this thing as a natural evolution. So when we look at the story about value-based care, there's a lot of conversation. It's, you know, managed care was 30 years ago. It's been a West Coast thing for decades. We are now in a legislative format of thinking of how do we integrate data so that we look at outcomes and cost, not one side or the other. So a couple of the talking points that we are seeing from an Oracle perspective, and my role as the strategist for for the data warehousing solution known as Oracle Healthcare Foundation is to think about all the different use cases of data that organizations would want to answer. And so we've got a platform that supports those questions, but you have to think about what types of data do organizations need to have available in order so that they can meet those federal, state, local initiatives, but then also meet their internal needs as well as their contracting needs when they go to market and negotiate with payers. So we think about things, we think that both payers and providers are seeing profits from this value-based care. It's not just, hey, I just got to see a patient and not have them readmitted. It's I need to see them, not have them readmitted unnecessarily, and also control how I internally spend. We are seeing the payers are somewhat slower. I caution about being, I want to say the reverse. Providers, the health systems, are somewhat slower on adopting this philosophy because they still have somewhat of a fee-for-service cushion, and you see that in the graph below. So payers have been much further along in that conversation. They've been doing it for several decades. We think about some HEDIS results going back. You know, HEDIS is on its 5th different version of what HEDIS means. So they've naturally had that data set that they've looked at. It's been claims-based. Providers have an EMR-based, and so getting those two sets of data together are very critical. But we see in the purple graph the payer space and the 2 and the 5-year projection. This is going back to the 2016 value-based reimbursement report, showing that it will tick down for fee-for-service, but it's not going away. And then also on the provider side, the green bars, we see that a 2 and 5-year projection from the 2016 year, there still would be a fee-for-service basis. And so that's something to be aware of, that it's not going to be a complete market. So we have to be flexible enough to have solutions and data sets and data analytics that support both sides. And we can go on to the next slide.
Excuse me, Leslie. This is Dave. In regards to the comment regarding providers being a little bit slow to adoption of these complete solutions, it's really been a function of over the last couple of years where they've gone through significant adoption of a enterprise-wide EMR, whether it's Epic, whether it's Cerner, whether it's other systems. So that's absorbed a lot of their time and efforts. Now that that's been completed, now they're thinking, okay, now how do I begin using this type of information, and how do I begin to understand how do I make this a throughput for my organization around the triple aim: cost, quality, and patient satisfaction.
Thanks, Dave. So tagging on that, we've got this slide and this some more view of the health plans and providers, but coming together in that common goal of the highest quality care at the lowest cost. And so someone from my background, I really think of more of the provider space and think of patients first and addressing the quality and the safety events on patients. Obviously, there's a good practical business side that we want to be the most efficient organizations, regardless of if it's a federal reimbursement, state reimbursement, or commercial reimbursement. We need to be wise financial stewards. So it's very clear that we're being legislated towards this, and regionally as well as different markets will pick up and adopt at different rates. And really the idea that we need to create in that second bullet on the health plan side, the visibility of the total patient cost. And it's not just the claims that come out of the provider space, it's the pharmacy, it's the follow-up, it's the PT, it's the OT, it's all of the pre-work, the post-work that goes along with the patient. We've long heard about episodes of care. We need to think about the continuum of care and not just saying that the patient was seen and treated for a heart attack and they got some outpatient follow-up afterwards, but rather what was their lifestyle coaching before and after, and how can we avoid having a second complication. So I really stress the idea of having a 360 view of the patient is integration of both claims and clinical data. Dave, your thoughts?
Yeah, I think thanks, Leslie. I think the other interesting phenomena is some health plans, an example would be Highmark United, they are purchasing or have purchased provider groups and hospital systems. So they have now become a payvider. And also a number of providers, large systems are building out health plans, whether it's a Medicaid plan or Medicare Advantage plan or a commercial plan. They want to begin to own the risk. And so we're seeing this melding of different business models across the industry. And the key in all this will be is how do you use data? So I'll give you one example. We were with one large health plan that owns a health system, and we used the word risk was used. And I realized after a half hour, that the providers were thinking about risk clinically, and health plans are talking about risk financially. So there needs to be what I call this bridge between the lexicons, what plans use versus what providers use.
Very true, very true. Next slide. And just focusing on that green box, we can call it data exchange, we can call it data aggregation. And so in my world, thinking of how do we aggregate once in order to serve all questions available for all different use cases today, 2 years, 5 years from now. Just because we've got legislation that's been passed today doesn't necessarily mean that it's going to be forever. That's why there's always going to be tunes and tweaks. So organizations need to have data that's available and organized so that they can be flexible to answer those questions downstream. So when we think about collaboration, the big impact and the transparency, it's managing clinical and financial risk. So as Dave uses the word risk, I think of it from a patient safety and outcome side as far as you can't get the triple aim unless you've done the right care at the right time at the right level of service. So we've got to be good stewards of our resources. We've got to be aware of how complicated the patient is, and we've got to be very attuned to providing them the best care at the best time. Well, in order to do that, you need to have capacity planning. So it's really looking, and we keep talking, and as we've gone through this conversation in just the first few minutes, we've really have exploded this view of all the different data that could be impactful to that patient's care, and it's not just a single stream of data, because in order to provide the triple aim, you have to have capacity. In order to have capacity, you need to know as far as your throughput in the organization, if your staff are ready, if your supplies are ready. It's very multidimensional. It's not just, hey, I got a claim file, I need to look at this, or hey, this many patients were readmitted, but it's looking at the complete collaboration of that data in order to plan for that patient arriving in the primary care setting or planning that they're going to be complicated. So again, organizations that are taking on risk need to be aware of what's in their population and what they could be exposed to. And I can't talk enough about quality outcomes. We talk about gaps in care, provider performance. I look at quality also as patient safety events. So ensuring that patients don't have bed sores, that they're ventilator-acquired pneumonia, that they don't fall. All of those things go to improving quality, and reduction of those go to improving quality. So we really need to look at everything that happens to that patient. Again, we keep talking about efficiencies in order to drive margin. We're in an organization, our industries average 2% margin, and some of them don't make a positive margin. So we need to be highly efficient, and we need to really get to a better business model. And how do we do that? Is by having great data available. The data may not be what you want to see, but if you can get it and if you can use it wisely and you're looking at the right types of data, then that's really going to improve the efficiency. Dave, your thoughts?
Just to give you two examples, in the world of EMR, there's probably thousands of data sets within an EMR. The question is, what data has value in understanding patient clinical risk and financial risk. So if someone has an HbA1c score of 6.0, the data would say, okay, they're not a diabetic. But if they have a fasting sugar level test of 128 or greater, that logic should trump the HbA1c, therefore classifying that patient as a diabetic. So that's the value of different lab values and trumping logics or prioritization logics. Same with social economic data, which is what we call ZIP plus 4 data, or ZIP household level income data, to determine if Dave Hom has an income level of $24,000 a year and the service costs $100 a month, the doability of that will be very low. So you have to adjust the doability of that service as a function of things like income, things like education, things like distance to the pharmacy, distance to the physician. So that becomes huge value for both the health plans and providers to understand what data has value incrementally, has that impact both clinical risk but also financial risk.
Thanks, Dave. Next slide. So Dave talked about a few different partnerships, and the title of this webinar alludes to the partnerships to drive outcomes. And so we've got payers and providers getting together. One of the other things to think about is why this market is driven. It's because we need to have both sides of the information, and sometimes we have organizational barriers that unless a joint venture occurs or unless a merger and acquisition occurs, we exist in silos. So we've got different flavors across the nation as far as, you look at Kaiser on the West Coast, completely vertical IDN, and then throughout the rest of the nation, we've got some of these partnerships, joint ventures, and then you still have other organizations that are completely siloed and don't have that access to that other side of information. But it is a driving force, and it is something that we're seeing catch momentum, because you have to have both sides of the equation in order to provide the best quality care and at the best efficiency. And I'll go on to the next slide. So that kind of brings into why Oracle and CO are presenting today, and CO has been very gracious to give me a few minutes here at the front. But for Oracle, we think of things as far as how do we consume, aggregate, integrate data from disparate data systems across the organization, regardless of the vendor. Being very agnostic as far as you could have XYZ EMR, you could have Epic, Cerner, Meditech, Allscripts, you could have all of the above, but you still have to have one spot if you really want to truly look at a single source of truth so that you can answer an integrated and collective view of response to those questions that you're trying to answer, as far as for quality initiatives, for the federal, for the state, any of the quality initiatives that you're trying to get to. So the questions that we always think about is, how do you aggregate the data for a single source of truth? How do you create complete longitudinal patient view? And that's from the social determinants of care on the upstream, any social coaching, any lifestyle events, your socioeconomic, your zip codes, all of those things on the upside, as well as all of the primary care, acute care, post-care that goes on, and then downstream after your event, not just an episode, but downstream, how do we look at coaching and lifestyle and family history of, and working with that data, and then creating an environment so all the data comes into one spot, and then the analysts and the users and the organizations, be it payers or providers, have that same access to that single source of truth. And how do we achieve? We also think about data governance across the organization. So when you name something that you're looking at it apples to apples, or if it's not an apple to apple directly, it's annotated. And that's very critical so that you don't have two different individuals looking at the data and saying, well, this is my number. Well, no, this is your number. No, this is my number. And we don't want to get into that. We've done very well as an industry within the U.S., not healthcare necessarily, but the healthcare financial space, because the financial space has FASB, has GAAP. We have very good rules as far as how to book a journal entry. We have very good rules on what we've called things. So that's a true apples to apples, and we work at really improving that on a day-to-day basis, because we've got audit and we've got compliance. We need to work that same diligence on the clinical record so that when we answer the questions, we're answering responsibly at the same time over and over for repeatability. So the little icons behind the blue box there are just how we think about the data sets that come in. It could be from claims, it could be from patient surveys, the HCAPs, it could be from surveys or assessments that are done in your provider office, your HRAs, your health risk assessment. It could be from other types of assessments. One of the greatest use cases that we use is one of our organizations wanted to do some pediatric work, and so the idea of picking up the Vanderbilt survey and scoring that, we've got a spot to put surveys into the Oracle Healthcare Foundation from that, so we can look at surveys that patients fill out, that providers fill out about a certain type of clinical event. A spot to inbound the data that comes from over from the school. So thinking about all the different data feeds that could come in, cost information, transactional activity-based costing, labor analytics, apps from wearables to different lab systems, from precision medicine, post-acute, it just goes on, and it continues to explode. I'll give another use case. Last year we were with a client in the Midwest, and they had this great idea of looking at patient safety. And while we know from a clinical event, if a patient harm event has occurred, a fall or a bed sore or ventilator-acquired pneumonia or any of the other never events, but they wanted to use the RFID chip off of their staff badges so that not to assign blame to a certain provider or staff member, but just the idea of looking at what proximity using an RFID chip of their staff in relation to when that patient fell, for instance, so that they could start to understand staff flows and just checking in on patients at different times. It's that way of using data that you've got to inform other information and other decisions. It's not just looking at it as, well, that patient fell, but rather, did it happen at a shift change? Did it happen from overtime? Did it happen because of lower nursing staff? Did it happen because the family member wasn't present? Did it happen blah, blah, blah? It can go on and on and on. Did it happen because the staff member was 2 doors away and was on their way to see them? A lot of different questions that come up, but the ability when we start doing quality improvement and looking in on how things occur, needing to have that 360 of that patient's data is very important. Dave, do you have any comments about the desperate systems?
Yeah, what's interesting is we did some work for a very large health system with regards to a shared savings ACO model, and they were on one large enterprise system, but they were on, and so we assumed that the system was consistent, i.e. the same version. And what we found when we started to pull in the 33 CMS quality metrics was that the data definitions, data files were different by different versions of this large system, ambulatory, hospitalization, different versions, and to pull the data was very difficult. And so the effort that it took was far greater than expected, and then there was a lot of confusion as to how they would actually use that data to improve their operations. And so when you begin thinking about what I call all these different disparate data pieces, how do you create the business case for what is the return on investment of this effort? How do I measure it? And then how do I qualify it over others? So are there prioritization rules that we need to establish for Project X versus Project B? And every health system has different what I call key stakeholders. So it goes back to Leslie's comment around data governance. Is there also has to be a governance model around outputs, and then the prioritization of those outputs based on some metric that there's organizational approval agreement on.
Thanks, Dave.
You're welcome.
So the final slide that I've got for my commentary is the idea of all data versus meaningful data. So we've listened to myself and Dave for several minutes here, and we keep talking about all the different data, and we've really created a very wide understanding of the data. But it needs to be meaningful data. So organizations need to prioritize as far as what data needs to come in order to help inform and make analytic decisions. So it needs to be the right data, not everything under the sun, but the right data. So we need to be really wise stewards, because again, it's a resource as far as labor to consume the information, labor to do the analysis on the data. So I want to just leave that as my final thought as far as data is great. I love it. I've spent my career thinking about it. I've spent my career thinking about how many different data sets I can consume to answer questions. But I'm very conservative on accepting new data or pulling over something if it has very low use or reuse. I'm not a fan of just accepting everything because we can, but thinking about what's the priority and what information we need in order to get that 360 patient view that helps us improve outcomes and reduce costs. So those are my final thoughts. Thanks a lot, Dave, and the CO team for inviting me here.
Just to add to that a little bit is on these different data sets, and this now begins to talk a little bit about the return on investments. One of the, if you look at the data sets to your right, there's consumer behavior data, engagement preference data. How do people want to receive information? Is it text, email? Is it robotic calls? Are there different referral patterns within the data? Are there different relationships of the data sets in terms of prioritizing prioritization logic of data over others? And I'll just give you, and you've seen this, where it's got what's called healthcare services data, sites of data, and then it's got all the medical RX data. looking at driving behaviors, one of the things that was compelling to me was people have said, well, there's a new world of Fitbit data where we're now capturing wearables. What data sets have value? And so when we have a large enough sample size, we begin developing analytics off of that based on a thesis. And so we track, so the historical myth has been is you need to exercise X amount of minutes per week in order to reduce things like adverse events. And now the literature says, okay, that's good, but what you need to do is not only adjust for duration, 30 minutes versus 60 minutes, but also for intensity. So you measure intensity based on your heart rate. What that does then, it looks at the person's ability to intensify the workout, which we now know from literature has a significant impact on items like hypertension, lipids, and diabetes, which are the three major condition drivers for our population as it ages. So intensity of the data workout becomes a new data set that can measure both clinical risk, i.e. reductions in blood pressure readings, reductions in the lipids, reductions in diabetes levels, HbA1cs, but also creating a output which will be improvements in health status at the patient level, but then more importantly, producing a what I would call a less adverse group to use events like ER visits, inpatient visits, extended length of stay visits, or even readmission rates. So the world of analytics, as you think about data layering and then sequencing the data layering, almost like the way specialty drugs are developed. So everyone knows in a specialty drug what ingredients are in there. What the secret is, the layering of the ingredients to create specific outputs. The same analogy can be used for analytics. Is what data has value? How do you test the validity of the data sets using, in our world, SAS logic and the predictive models? And then two is validating those models in the real world, reducing false, and when you identify false positives, then you adjust the independent variables to reduce the variations in outputs, and therefore reducing the levels of false positives. So that's, for me, the excitement of data and analytics, and create what I call throughputs. So next will be is this is how we think of the world. All these different data sources that are coming in, and then how do you then transform the data at the patient level, or the claim line level, and also at the provider level. When you do it at that discrete level, it allows you then to create thesis or hypothesis to create specific outcomes, whether it's claims for things like waste and abuse or gray zone medicine. If it's dealing with at the provider level, are the providers being reimbursed correctly by CMS for their HCC codings? Is there revenue that's lost because of poor coding? At the patient level, are patients being managed correctly? Are they being risk stratified correctly and identified correctly? So the data transformation and data processing is probably 75% of the battle, and the effort to convert this data into meaningful information at the patient level, claim line level, and provider level produces analytics. Then the question is then how do you digest it, and then how do you create visualization layers? And all the visualization layers and allow you to identify what are called hotspots, almost like Doppler radar, identify emerging issues, trends at the patient level tied to physicians, and then allowing you then to act on those emerging issues in advance of the poor event. So poor event could be around quality, could be possibilities for readmission rates, when we see a fall off in things like, does the patient post-surgery go back in and visit the physician within X amount of days? Typically the answer is no, for a number of different reasons. They're not feeling well, they can't get there, the caregiver can't drive them there. And so then the question is then how do you use that information to improve quality outputs and also population management? And then more importantly then is, are the networks being managed effectively? Are physicians being scored from a quality and cost point of view in a thoughtful way? Okay. So this is like Candyland for those of you who have young kids, and I will say that my kids now are 18 and 22, so they may not understand this model anymore, because unless it's on their tablet or on their phone. A little humor to that, but not much. And now Stacy's going to send me a text to say, Dave, off the humor, off the humor. But the theory behind this journey is first around quality, first and foremost. Quality metrics, you can use the CMS 33 quality metrics. You look at pay for performance historically. You can look at how value-based contracts impact the provider groups on a future basis. You can look at things like macro and myth, pre-post, and projecting going forward to allow you to answer the question of, am I going to make more money, less money, or equal money than last year, either a hospital system as provider? How do I understand my populations? Where the risks are going on a go-forward basis? Or referral patterns, when I refer someone to a specialist, do I understand if they're moving to a patient moving to a skilled nursing facility, home health care, how the services are provided, and how they're being measured? And again, it goes back to Leslie's comment of the triple aim of cost, efficiency, and patient satisfaction. Okay. So now this is a little bit about the ROI and from the outputs, and so this is how we think of the world, and this is how our customers have commented on their specific needs. First one is in the area of managing risk and revenue. Am I being paid correctly for the patients in which I'm managing? So whether they're a Medicare Advantage patient, or they're in a managed Medicaid plan, or if I'm on a bundle payment, or I'm on a pay for outcomes, define it in terms of how you want it. Am I on target? And if not, why not? Then how do I manage those more in a proactive way? So the business intelligence visualization layer allows me to see by geography, patient risk going from pink to dark red, like Doppler radar means I have emerging issues. And it has an impact on my reimbursement, and also allows me to understand how the physician groups are being managed across the multiple health plans that provide services to my patients. Second one is on payment. Well, we know that a lot of physicians and a lot of hospitals submit claims. A lot of claims are done inappropriately, and so their claims get appended, and there's a delay in the payment. And even for some cases, it may be considered to be wasteful or abused, and therefore goes into a second set of audit process, all of which delays income to the providers. So how do you begin to think about, how do I get paid correctly? Are my processes of how I submit bills, are they appropriate? How do I measure those payments versus what I had budgeted for? And then how do I understand the need of what I call clinical review to justify my use of those additional services? So, and the biggest item I think is, the shift from inpatient to home health care / skilled nursing, durable medical equipment, where many of the health plans have paid as percentage of charge, but because the systems, haven't been updated, but the systems of reimbursement now are changing, and so there's now a deeper focus on ancillary services. Even though the units of services are high, the dollars are low, but the total cost is high or an increase at a much faster rate. And then there's, a third bucket is around quality and compliance. And this ties back to both the plan and to providers around, are the gaps in care being managed correctly? Am I getting, do I understand the patient does have a gap? Because when you ask a patient, use me for example, when a doctor asks me, Dave, do you take your medications? I say, well, it depends. Because I travel quite a bit. And she says, Dave, that's not the question. That's the answer is, do you take it every day? And so that is considered a gap in care, and therefore there needs to be closure around that gap in care. This concept of gray zone medicine, where for certain surgical procedures, those would be hips, knees, shoulders. Those will also be for urofibroid stents, where in bariatric surgery, where tends to be excess use of those services, and it's a function of supply side, but also a function of demand side, is how do you begin identifying folks that may need those types of services? How do you then intervene earlier so that there's educational process, nutrition counseling processes, counseling with the caregiver of the patient, could be the child. And then how do you then, if the surgery is needed, then how do you identify the right provider services to some sort of center of excellence? And then this alignment of resources and touch points based on risk is a lot. We do this for a lot of Medicaid plans, which is every year a patient sees a physician, probably they see him 5 times a year. That's 10 minutes. That's 50 minutes. That's about an hour at most. So in that hour of time, does that change behavior of the patient? And typically the answer is no. And so what you need to figure out is, based on patient risk, high risk with high gaps, how do I touch the patient more often with other interventions, whether it's texting, email, whether robotic calls, whether it's nutrition counseling, so that the touch points go from an hour to 5 to 6 hours. We know that in the data, when there's higher levels of touch points, there's a significant improvements in the patient's risk, leading to reductions in adverse events. The last, at least, is the network optimization, which is, are providers tracking to be efficient and effective? So a lot of providers to this day, they may not realize that when they do a referral out for a high-tech image, that the variations and reimbursements can be highly varied. Or if there's referrals into certain physician groups, specialists, that there's high variations in practice and cost, and also within the hospital system. So looking at providers from a cost, and this is why claims become important, to educate providers on how they're impacting both the patient, who may be at a very high deductible and would end up paying for a majority of that cost, and who may not be able to afford it, and therefore there'll be some what I call future billing issues. Looking at things like managing readmissions or extended length of stay, predicting probabilities of that has a material impact on health plans and health systems that are at risk, and looking at referral patterns, as I talked about before. So this is the way we look at it. It's cost and revenue, short-term. There's also short-term wins around improving workflow processes for payments. And cost and quality and compliance are what I call savings that can be achieved beyond year 1 and 2. So going with short-term wins, and then look at things you can do on a go-forward basis to achieve what I call credibility with key stakeholders. Okay. So a little bit, and this is for the folks like me who wear bifocals, means I see this, but it's not as visible. But what this basically says is, how do I identify patients and patients' risk? And so today, any predictive model says that if Dave and Leslie are two individuals, Dave's had we both have three conditions: diabetic, hypertension, hyperlipids. But I've had a hospital event in the last 12 months. I'm predicted to be high risk. Now, Leslie, who has not had a hospital event, would consider to be moderate risk, but she's got 6 gaps in care. So clinically, she's at a higher risk, or could be at a higher risk than Dave. So how do we then identify in what we call in our world impactability, calling out all the Leslies in the world that have high cost, high impact because they've got care gaps that are significant, and then how do you then proactively outreach to them to drive reductions in care gaps? So this is the thesis of this, which is a different model than most organizations have today in the at-risk world. Okay. So then this talks about then is once I get the patient, what we have found with a lot of physician groups is there tends to be undercoding for both Medicare Advantage patients. So I'm in a plan with Humana or Blue Cross or with United and others. And so I get, the providers get paid by CMS based on an HCC code. What happens typically is for a lot of different reasons, where there's poor administration, poor capturing of data, poor capturing of those risk scores, the physician groups tend to undercode for many of their patients. Therefore, they receive less revenue, and therefore it has a material impact. So the question then becomes is how do we use analytics to identify patients and their ACC codes to determine whether the provider groups are being paid correctly, and then tracking those scores over time. So this requires a significant amount of data capture, but it has an immediate financial impact that's positive to providers and for health plans that go at risk with CMS. Okay. Next. And this gets into then what I call the longer term savings, which is quality and compliance. So when I showed you that roadmap on quality always takes time. And so what we think about quality is a lot of this is the basis of some of the CMS 33 quality metrics is how do you measure quality at provider group levels. You have to have enough patients by provider groups to create the metrics. But then you can also look at different provider groups, A versus B versus C, and create benchmarking. Everyone likes to be benchmarked, and that's the chart to your right, which is around the benchmarking. And then you use this process to begin educating the providers and their administrative staff on things they need to do to improve. So are they missing care gaps? There are not follow-ups on things like HbA1c tests for diabetics, eye exams for diabetics, foot exams for diabetics, and shown them that these patients without those metrics risk may be getting worse, and therefore they would end up having some sort of adverse event. Okay. There's 3 more slides and give you the journey. Okay, next, Stacy.
You should be seeing the network optimization slide. Do you want me to go to the next page?
Yeah, yes, please. Okay, so let me go back. Let's go back one, go back one, go back, and let's go back one. Yeah, so this here is an approach on how effective is my network. I can measure both cost and quality, but also look at referral patterns. And so are people going outside the system my system within my hospital system for what procedures and why, and we call that leakage. It also has a material impact on the patient because some of those claims can be considered to be out of network, and therefore the patient has a higher out-of-pocket expense, and therefore creates issues on payments for a lot of folks where there's high medical expense, where they have a high deductible plan for themselves and for their families. So this gets into benchmarking, showing comparisons, showing the variations in provider scoring, why it occurs, and this has to be really done at the local level, particularly at the zip code level, MSA level, because you'll see different practice patterns by different provider groups in different parts of the country. And so it's important to adjust the data for the specific, what are called local area of practice. Okay. Next, Stacia.
Having a little delay in the slide transition.
Yeah.
To catch up.
It's probably delayed because of the game last night at Oracle Stadium in San Francisco created there were two people that paid $133,000 for each seat to sit on the court side, which to me was amazing. How someone could spend $250,000 to see a game, but it was at the Oracle Arena in Oakland. So in terms of partnerships, we have a core belief that no one has all the solutions to bring to the market, particularly around these ecosystems of health plans and providers, where there hasn't historically been a lot of collaborations, and the data sets are complicated and difficult to work with. And so we said, Oracle has that expertise, has that emotional engagement in making a difference, and so we said, let's figure out a way to partner with them because we do the back-end analytics, and so we think that the partnership on having data storage, data integration, data management, the whole data cleansing ELT process is highly critical in creating what we do at CO, which is around creating short-term and long-term savings. The other ecosystem that's emerging is health plans and life science companies. Those would be specialty drugs. Those would be pharmaceutical companies, where the same collaboration will be needed along with the health plans. And then the last area we think will be a huge growth opportunity for the market is the integrated delivery networks. There's a big, large systems and life science collaborations where all this information would be of high value. So I'm going to say, thank you for everyone for A, listening, and B is if you can score me on the humor chart, B out of 1 through 5, a 4, that would be helpful because I get paid additional dollars on that for outcomes.
Dave, I have faith your score will be very high.
Yeah, no, I don't think so. I don't think so.
Okay, folks, that concludes the main component of our content. And like I said, I encourage you to input questions in the questions or chat section of your pane. We have received a couple of questions so far, so I'll just kind of start going through them here, Dave and Leslie. So the first question we have is, how does one categorize the impactability of a patient? Dave, I'll put that to you.
Yeah. So the way the way we, how we think about it is, Dave and Leslie are both patients. We score at the same type of risk, similar risk, but Leslie has 3 gaps in care, but I've got 9 gaps in care for my 3 conditions. So what we've done is answer the question that becomes very prescriptive, which is Dave now becomes a higher risk than Leslie because she only has 3 gaps, and 3 gaps she's got are non-material gaps. I've got gaps in care that are considered material, so those would be things like hypertension medication for diabetics, my diabetes medication, and my lipid medications, where by not taking those medications or even scoring on my HbA1c test versus my fasting sugar level test will indicate that I might be at a much higher risk than what the claims models or the EMR data shows. Therefore, I should be prioritized over Leslie. And then the outreach by the physician groups or the health plan gets pushed to them that when Dave, that Dave needs to be called in, we need to talk to Dave and to engage Dave with more of our time.
Great, thanks, Dave. Another question here is, you mentioned data maturity earlier. What causes the delay? Actually, I'll ask you to take that one.
Yeah, data maturity. So I think it's organizations. Thanks, guys. The organizations they struggle with what goes first. And so typically they've got a burning plank. We've got to answer this. 5, 6, 7 years ago, it was meaningful use, meaningful use. We've got to get the EMRs up and running. We've got to show interoperability. We've got to. So, it was core, it was menu, 30-something measures a handful of years ago. And so they start accumulating information, accumulating data. And then a couple years into it, they look around and they're like, wait a minute, we've got all this good data. What else could we answer with it? Or someone sitting across the table from another decision maker, and they're trying to figure out if they need to go buy another service, and they're trying to answer a certain question, and the person that owns or housed the first set of data says, well, we already have that stuff in the system. We can just help you out. And I think that's part of where the data maturity has come from, or because it has to grow from the provider space, from my 25 years in the provider side. Payers, while they still have certain levels of maturity, they still started with, here's a claim file, here's a claim file. Now they're growing into the social determinants and a lot of the more non-structured data forms, but they really took the big data sets to start with the claim files. Organizations on the provider side have grown into it because they started looking beyond just the EMR file. They started looking beyond just the service line. They started looking beyond nutrition reports. They started looking beyond what's my census number. And as those organizations develop more maturity and looking at, oh, these are all the questions we're trying to answer. These are all the customers that are asking for the information. Oh, we've got to have information available on a portal. Oh, we've got to be able to provide this to the patients. That has pulled the maturity curve along. Thank you for the question.
Yeah, I'll give you an example of a customer. So we were building out a series of business intelligence layers for a number of physician groups, and that was being delivered by the health plan. And the physician said to us, wow, I didn't realize that this health plan has all this data about my patients. And I'm now being scored on it, and I didn't even know that I was being scored on it. And I didn't even know whether I can even control it. So there is a lack of knowledge on both sides, payer provider, on types of data that's being used and how it's being used, and how fast it gets refreshed.
Yeah, that's good, Dave. And that kind of leads into the next question that we have. You touched on different uses of behavioral type data. So the question is, how are you seeing both providers and payers using behavioral data?
I'll give you an example. This is a great two quick examples. So a large health plan in New York said, hey, we want to improve our star ratings for HEDIS for Medicare Advantage. And we think, that the model weights and the star ratings, 20% of it's allocated to drug compliance. So So our PBM thinks, we should do drug compliance, and we want to do a mail order. And they said, well, let's look at the data. And we looked at data, and we pinged the patient or member to a location because we had their eligibility data. The build, the location to whether it's a high rise or whether it's a single dwelling. And I said, the trouble is that 80% of your patients live in high rises, and the mailbox is only two inches wide and 6 inches high. So you can't put a 3-month supply of drugs in there. So you got to put a postcard in there to say, go to the post office, which is 3 blocks away and 2 avenues away. And I said, it's not doable. And so that's an example of throughputs. Second one around behavior economics. Second one is in Florida, another plan said, we want to improve compliance, but we want to get people to the drugstore. It's different, instead of mail order, into the drugstore. And so we pinged the patient. We looked at their local pharmacy, and then we took some samples, and we geomapped and a travel route, and said that for these patients they had to make 2 left-hand turns to get to that local pharmacy. And an I-41 in Sarasota, that's not doable because that's 6 lanes of traffic. So having that type of knowledge about the patient, about where they live, is important in terms of, is it doable by the member patient?
Very interesting. Thank you. I think we have time for maybe just one more question, and this is, still really kind of rolling on the same idea. So how are providers who typically haven't had access to claims data using claims data today, if they do gain access?
Do you want me to take that one?
Sure.
Sure. Leslie?
So I think that from what I'm seeing, our existing installs from a provider side, they're now putting their toe in the water, and they're asking for the claim files so that they can look at what's going on. We talked about earlier leakage. So what happened with that patient 360 on their set of patients? Did the patients do follow-up? Did they get their pharmacy filled if they didn't fill it in the building before they left? So thinking about that longitudinal case study. So they're starting to experiment with it. There are along different maturity curves. Some of them have got their own health plans, and they're doing that type of thing. Others are starting to absorb, and they're looking at how do they match up claim activity with the clinical record so that they can look at longitudinal. And then we still have some other clients that are starting with different use cases. And so it's along that maturity line, but it is something that everyone wants to discuss. It's just there are different levels of execution.
Okay. Thank you so much. And that concludes our Q&A. And I'd like to thank everyone who joined our webinar today. Thank you for taking the time to sit with us. And a big thank you to both Dave and Leslie. I think I can award you both 5 stars here. And we appreciate your expertise, your insights on this topic. It's been really great going through this with you. So a reminder to the audience that today's session was recorded, and again, we will send you the recording as well as access to the presentation today in about 24 to 48 hours. So this concludes today's conference. Thank you for your participation, and have a wonderful day, everyone. Thank you.
Bye now.